Hi there, everybody. I'm going to record on drugs for asthma and COPD. So for this, there's about 48 slides, but my plan is to not take 48 minutes. Usually I always account for like a minute a slide, so hopefully it won't be that way. Okay, so let's get started here. Let me start the slideshow. All right, so first we're going to talk about, let me move my screen here. Oh my gosh, why did it stop? There we go. Okay, so let's talk about asthma for a minute. Asthma, and I put in red really important things that really you should circle, print out the slides, remember, learn about it, etc. So asthma and COPD, the difference is asthma is reversible and COPD is not reversible, meaning in COPD, once the damage is done in your lungs, it's done. There's like really nothing, there's no medicines out there that we can bring back your lung function that's already been damaged. So once you have the COPD, we want to prevent further progression of that disease. Whereas asthma is reversible, something will trigger it, and then you have a bronchospasm, you take your medicine, and then it goes back to normal, so you don't have any lung damage, all right? So this is chronic reversible inflammatory disorder of the airway. Some signs and symptoms are basically the same for COPD and asthma: coughing, wheezing, some chest tightness, and shortness of breath. Usually you diagnose with a pulmonary function test, but not always. Sometimes we give you an inhaler, and if you respond to the inhaler, then we think, yeah, you probably do have some asthma. Not all asthma is going to be exactly the same. Some have just exercise-induced asthma, allergy-induced asthma, illness-induced asthma, or you have that chronic asthmatic that we're used to hearing about. And then your COPD. Think of COPD. I know I use the umbrella a lot. Again, an umbrella is COPD, and underneath it you have chronic bronchitis and emphysema underneath that. So it's chronic, it's progressive, and it's irreversible. So when you go back to your anatomy class where you have the alveoli in the lungs, I think of the lungs as an upside-down tree, and in the branches at the bottom, you have the alveoli down here, multiple ones that exchange your oxygen and other gases, carbon dioxide, and you end up retaining more than you lose more oxygen, and you're not able to get that exchange like you should. So still the same kind of characteristics, symptoms, but usually with later symptoms, like I said, it's a chronic thing. So they start having where they can't walk far. You see them on oxygen all the time, and you can be your immune system goes down, so you can get frequent infections. And the main cause is smoking cigarettes. It damages the lungs. So an overview of the get back here. Overview of drugs for asthma and COPD. So I tried to put this so you can kind of get a better understanding. So there's anti-inflammatories, which can be primarily used for asthma, although steroids fall under anti-inflammatories and can be also used for COPD. Bronchodilators, that dilate your bronchioles. There's short-acting and long-acting. So short-acting is your albuterol that you take, that you've heard of people using, and that works within like minutes and can last a couple hours, 2 to 4 hours. Whereas then you have long-acting, which is longer acting, and usually that should only be mixed with steroid over here. They did a study quite a while ago that showed that your the fatalities and death rate goes up if you just use this long-acting by itself. Ceravent used to be one of them. I think Ceravent's still out, but I never see it used. This Methylxanthines, theophylline and aminophylline, you don't see it too much anymore. These are pills. Theophylline, you'll see in some old-time COPDers that have it's worked for them. Those dilate your bronchioles. Then we have Singulair, which is only used for asthma. It's a monoclonal antibody. It's used specifically for like if you're not responding to other medicines. And then we have Anticholinergics, which are used primarily for COPD. This is just to give you another idea and see a picture of it. Relievers versus controllers. So relievers, you know, things like if you're having an asthma attack now, or if you have COPD and you're like walking upstairs and you're real short of breath, you use one of the short acting, and then the anticholinergics, which are only for COPD, you would do that, you know, in the morning and at night before bed. And then you have these long-acting beta-2 agonists, which I'll show you some more, but these really, people should not be using these alone. Here's the combinations that people use, and then here's prevention ones, which would be your steroid inhalers, which goes along with combination too, because you can use steroids by itself, but a lot of times we'll see them mixed in with a long-acting beta agonist, and patients can tell the difference because they start feeling better because they have that bronchodilator in with the steroid. So inhalers at a glance. Now HFA is used. It's like an aerosol, but it's it's an aerosol, but it's safer. It's not like messing up the ozone layer or something. So they changed to HFA, so it's mandatory that it has to be that. But if you do have one that's an HFA, you should really be using a spacer with it. So all your albuterols, things like that. So I have some, which I'll bring to class. This is your typical inhaler here. And it's good to have a spacer in it. So if you haven't seen it, it's like a longer tube that hooks up to it, because they say the timing, by breathing it in, you end up blowing out a lot of it. But if it goes in the spacer first, it gives you some time to breathe it in and get it into your lungs. So anything like this, okay, you need a spacer. Is it always done? No, you don't always see it, but it's recommended. You need some hand-lung coordination with this aerosol, but some of the other ones you don't. So like here's one that actually, if you can see this, you just open it like that, and that clicks it into place, and then you put your mouth on this and just breathe it in. And then that puts it into your lungs. So you don't need a spacer for one of these. Some have pills like Spiriva. It's a little powder tablet you put in a cartridge and you just go, and so you don't need that. So you don't need the hand-lung coordination like you do with the aerosol. When you see MDI, think meter-dosed inhaler. So it's just another word for inhaler, meter-dosed inhaler. A lot of the inhalers have numbers on it. Like this has 6 doses left. Again, I'll bring it into class tomorrow. All right, so we have anti-inflammatories, which under that is your corticosteroids are for asthma and COPD, your leukotriene modifiers for asthma, and your cromolyn, that's for asthma. It's just one that sits by itself. So let's go over those real quick. All right, so this is the foundation of asthma therapy. It's taken daily for long-term control for those people that have moderate to severe asthma. The principal anti-inflammatories are your glucocorticoids or your steroid inhalers. My thing keeps moving. Steroid inhalers, for example, your budesonide, fluticasone. So as you can see here, all right, so these right here are steroid inhalers, those pictures. So this is Flovent. It just has an inhaler. They do come in different doses. This is an Asthma Next. This you do not need a spacer for because it's similar to what this looks like. I'm trying to get the camera. This is actually a different type. It's anticholinergic, which we'll go over, but this is similar. So all you do with this, is you twist it and see it goes out. You just put your mouth over it and see the powder. It just goes out like a little tiny aerosol. And Q-var also. So these are just plain steroids to help reduce inflammation in the lungs. So what's it used for again? It's used for prophylaxis of chronic asthma. So people that have that moderate to severe asthma and need to use their inhalers a lot will end up being on a prophylactic dose, meaning they'll be using their inhaler, depending on the drug, either once a day or twice a day to keep that inflammation under control. But it's always start low and go slow. because there are different doses to these inhalers. So we don't really want them on the high dose because you can get side effects, remember, because it's a steroid. And it's not used to abort an ongoing attack because, remember, it takes a while for this to start working in the lungs. It's a fixed schedule. It's not as needed. So what does it do? Remember these things. It reduces bronchial hyperreactivity, not increase, it decreases it. It reduces edema of the airway, so any swelling of the airway, it brings that down. And it increases responsiveness to the beta-2 adrenergic agonist. So I'll show you, do I not have one with me? Yeah, I have. So the Symbicort right here actually has a long-acting beta-2 adrenergic agonist in here. All right, so, and it also has a steroid. So by combining both of them, I say open things up and reduces inflammation. So the beta-2 adrenergic agonist opens up your bronchioles. The steroid lets the medicine go in and reduce all that inflammation. The short-acting beta-2 adrenergic agonists are like your albuterol inhalers, Proventil, Ventolin, those emergency ones that you have on hand. So again, if you have this on board, the long-acting, and if you're short of breath, you can use your short-acting if you're short of breath. So it works hand in hand. Not everybody is on a steroid inhaler though. All right, so sometimes people have to take some prednisone pills. Usually if they're having an acute exacerbation, they come in and they're just having an asthma attack and they're already taking a steroid inhaler such as this, and we need to breathe, so we'll put them on some prednisone pills. So if you're having an exacerbation, even with COPD, if you're having an exacerbation, you need to be on some prednisone. There are some people that have COPD that are on a low dose of prednisone. That's usually if you're end-stage COPD, because treatment should be as brief as possible. As we learned at the last one, there's a lot of side effects to that. So here are some adverse effects. Although they can end up being the same as taking oral prednisone, but for the inhalers, really pay attention to, hoarseness, coughing, dry mouth. Think about what can happen. You're reducing the immune system. You're providing a haven for fungus. So laryngeal fungal infection are the most common side effects. So that's why you have to tell them you have to rinse your mouth out every time you use a steroid inhaler. So if it's twice a day, you tell them to rinse their mouth after each use. Okay, so other adverse effects, which we talked about in the last section or chapter with your last exam, but also don't forget about osteoporosis. So just because someone's inhaling something into their lungs doesn't mean that doesn't go in the rest of their body. So these people, you have to watch out for that. Make sure, like, you check a bone density, do the calcium, make sure they're taking some calcium and vitamin D. So in young patients, though, growth suppression they can have, but it does not reduce the overall adult height. So if somebody is severe asthmatic, as a child, and they're using these steroids every day, it can suppress their growth for the temporary being, but they'll eventually grow to the adult height that they're supposed to grow. So these are some really important teaching points. With any inhaled steroid, instruct patients to rinse their mouth, which I said, and that's to avoid the fungal buildup, infection. Do not have them DC the medication, but if they're having hoarseness, make sure they're rinsing. So look to see if they have an infection. If they tell you that, you can't say, well, let's stop the medicine, because they obviously are using it because they have trouble breathing. You need to breathe, right? So let's say, all right, let's take a look. Maybe there is a fungal infection that we need to treat, and so let's take a look. And then another good point, if they use a lot of these inhalers require taking 2 puffs, so tell them to wait at least a minute between inhalations. Okay. Here's a little bit of the pharmacokinetics of it. So the meter-dosed inhaler, again, MDI, you're putting it in, so approximately 10 to 20% inhaled. Oops, I got a fruit fly around me. 80 to 90% is swallowed. And then we have some absorption in the GI tract, which is in the liver, and systemic circulation. So one part goes into is swallowed, goes through GI tract, and then 10 to 20% is inhaled into the lungs. So that's how it works. So not everything's going to go into the lungs. That's why a spacer is really important to use. Okay, so we talked about steroids. Let's talk about leukotriene modifiers, which we talked about in the last unit. Singulair, which you can see on the bottom, it's a pill and it's used only with asthma. Not to say COPD patients can't have it, because sometimes they have mixed asthma also, or allergies. So remember these. So they can cause some mood changes in children. It's not used alone. So it's usually not first line, but it's added to current therapy as an adjunct treatment. I saw a patient this last weekend who had asthma exacerbation. She had run out of her Singulair, so we had to put her on some prednisone pills because she was already taking the highest dose of a steroid inhaler. She was using her nebulizer at home constantly. She said she ran out of her Singulair, so we put the Singulair back on board, and that helped a lot. So it's used with something else, adjunct. It comes in 10 milligram tablets. There's only one dose, and you take it once a day. So what this does is it reduces the constriction and inflammatory responses. So remember the leukotrienes that we talked about? Well, this is another pathway that maybe we can see if you respond to it or not. That you either respond to it or you're not going to respond to it. This is not really used anymore. This is just another one, a leukotriene modifier. I've actually, years ago, I've heard of it, but it's really not given. It's Singulair is the mainstay, and now it's generic, so you're going to see that. And this one, too, you're not going to see. I'd be surprised if you ever saw this unless someone's been on it for years. Singulair is the most common. Really, side effects are pretty good. There's not too many side effects to Singulair. It's pretty well tolerated. All right, cromolyn is another one which is rarely used, but it's used for prophylaxis, not quick relief. It's for asthma patients. So remember that. This cromolyn's only used for asthma patients, and it's good to take 15 minutes before exercise. It suppresses inflammation, and it works with histamine. So it's not a bronchodilator where it's just dilating your bronchioles. It's helping with inflammation because it's working with histamine. So it's good for patients that aren't needing to exercise. So you take it, wait about 15 minutes, start exercising. All right, so there is one medication for asthma. It's a monoclonal antibody. We hear a lot about those for like immunosuppressants, people with rheumatoid arthritis, autoimmune diseases. But there is one for asthma. It looks like my picture kind of, oops. Let me see if I can get to that picture. Nope, it didn't work. Okay. Hold on. All right, so it's Xolair, and it's an antibody, and I'll make sure this is fixed while you print it out. It's for moderate to severe asthma, and it is used, usually they'll be taking steroids anyway, so it's really for people that have not responded to a lot of the steroid medications, things like that. So not everybody goes on Xolair. Usually you're seeing an allergist, and then you've tried things, and you're having difficulty of severe asthma, and then they'll try this monoclonal antibody. All right, so let's talk about bronchodilators. Now, what is this SABA and LABA? SABA is short-acting bronchodilator action, and then LABA is long-acting. So you have short-acting, long-acting, then we have methylxanthines. So you can look on that chart in the beginning if you want to like get it all in your head again, what these are. Bronchodilators come in short-acting or long-acting. Your short-acting would be your albuterol, your Proair, your Proventil, your Ventolin. Those are the brand names for albuterol inhaler. Your nebulizer treatments that you're doing at home, breathing in, I say smoking the pipe, that's going to be your short-actings. We have some long-acting liquid forms that go in the nebulizer. Long-acting we talked about, which would be your Ceravent, which it's not used alone. Usually mixed in with the steroid, and now it's mixed in with some other things which we'll talk about. And then we have methylxanthines. These are used for asthma and COPD. Bronchodilators, they're the bronchodilators. So it's easy to kind of remember those because they dilate the bronchiole. They have nothing to do with reducing inflammation, but they do open up your bronchioles. So most cases, patient taking a bronchodilator should also be taking a steroid for long-term suppression of inflammation, which is why I have the Symbicort here, has both in it. It has the long-acting and the steroid in it. Your albuterol you can have on hand and not be on a glucocorticoid. So when I say in almost all cases, we're talking moderate to severe asthma. People that have mild intermittent asthma usually will just have some albuterol on hand, and they should not be taking it more than once a week. If they're taking it more than once a week or waking up with nighttime symptoms, that tells me you're not controlled and you really need to possibly go on a low-dose steroid inhaler. So, which I talked about the SABA and the LABA. So here's some pictures. We have the Proair Proventil Ventolin. It's used in both asthma and COPD. They usually have them on hand with them. I usually prescribe 2 to keep at home, and then 1 in their purse or 1 in their car. It's to be taken as needed. You can take this before exercise to prevent an asthma attack. And also, people that are hospitalized, you are using it by nebulizer. So that's the gold standard, the treatment of choice, to give like a high dose, long-acting nebulizer of the albuterol. And when you see MDI, that's meter dose inhaler again. All right, so we talked about short-acting. Now we're going to talk about long-acting. So what this is, these are for people that experience frequent attacks, is long-acting over short-acting in COPD patients. So long-acting is preferred over short-acting in COPD patients. COPD patients usually will always have a short-acting hanging on their body somewhere, but they really should have a long-acting on board, whether it's in the steroid inhaler. That's usually where they put it. So people with COPD are on more than 1 inhaler. With these, dosing's a fixed schedule, not as needed. It's effective in treating stable COPD, and when used to treat asthma, must always be combined with the glucocorticoid. Using alone in asthma is contraindicated. All right, this is your methylxanthines, which you won't see as much. You'll probably end up seeing theophylline out there, although it's pretty rare. It's people that have been on it for a long time. It's rare use now. It's for maintenance therapy, and it helps with the inflammation. Usually, remember, you have to avoid caffeine with this, and it's no longer recommended for treatment, but not to say that you won't see it, because some people that they're already on it, they just stay on it. So anticholinergics. So this is really a mainstay gold standard for COPD patients. So what this does is it relaxes the bronchial smooth muscle, blocks the action of acetylcholine, which is known to constrict your smooth muscle. But remember, with anticholinergics, with some of the other medications that we talked about before, like for prostate health and things like that, it can cause dryness. You can have that constipation, dry eyes, dry mouth, urinary retention, nasal congestion. Think about that. Remember that with anticholinergics. So I have an anticholinergic. This would be this one. It's your Respimat, Combivent Respimat inhaler. No, let's see. Let's do the Spiriva. Spiriva is the one, not Combivent. So we have Spiriva Respimat. That's an anticholinergic. That relaxes your bronchial smooth muscle. It's real important for these COPD patients to have this on board. Sometimes we even give it first line for them. Here's some like Spiriva. Now they changed the Spiriva to this Respimat one. So this one here, you would put like a little capsule in, but I believe that's off the market, and I think they have just this out now, which lets out that aerosol spray. Tudorza's out. Incrus Ellipta is new, which I have right here. That is... what do I do with it? But that looks like this, basically, where you put it down, it releases it to use, put your mouth on it, and inhale it in. And then there's the generic Spiriva. So it's long-acting. It's used for bronchospasm, because think about it's relaxing smooth muscle, right? So if you're having a spasm, it's supposed to prevent all that. It's only for COPD patients. Because the COPD patients have that irreversible issue, so they need as much smooth muscle relaxation, prevention of bronchospasm as possible. This looks like a really old picture here. So what else does it do? It improves lung function. It blocks the muscarinic receptors. So that's basically the smooth muscle receptors. Tudorza we talked about. Tudorza is not the newest anymore. Incruse is the newest. So Tudorza was the one right before Incruse came out. There's a lot of them that keep coming out, and it's hard to keep up with them. But again, these work with the smooth muscle relaxer, muscarinic receptors. The peak levels occur within 10 minutes of drug delivery. It's for maintenance. All of these are for maintenance and yet not used for acute symptom relief. When you're thinking acute symptom relief, think your albuterol inhaler. Remember these teaching points. If you have constipation, actually this should have been in red. Fruits, vegetables, fiber, to treat that. So don't automatically think, let's give a stool softener. When you're doing your teaching, think about dietary stuff we can do. And for a dry mouth, what can they do to help stimulate those salivary glands? Give them some, tell them to be like Jolly Ranchers, lemon drops, if they're diabetic, some sugar-free candy. And now we're going to talk about the combination steroid and long-acting beta agonist. You won't see steroids in short-acting. Short-acting is alone. That's your albuterol. You'll never see that combined with any other medication. The long-acting you'll see combined with the steroids. It's used for both. As you see here, there's the Advair, which you don't need a spacer. The Brio Ellipta, which, do I have Brio? Nope, I have a Noro Ellipta. Brio Ellipta is another one, and then Dulera. So these are all combinations. Like, for example, let's look at this Advair right here. It's in the powder form, 1 inhalation twice a day. You don't need a spacer because you don't need that hand-lung coordination, because you just put it over the mouthpiece over your mouth and just breathe it in. It's not like this where it's harder to breathe in and get a good seal around your mouth. So they've really come a long way with a lot of inhalers. Symbicort, which I just showed you, this one you need a spacer for, and then Dulera, this one over here in the corner, you need a spacer for that. It's for long-term maintenance. Children and adults can have it. Usually we don't start them on this, because if you don't need a steroid, why go on a steroid? And it's also used for prophylaxis to prevent exacerbation. So someone with more severe asthma or moderate to severe COPD. How do we manage asthma? Well, we do lung function tests. So it's called forced expiratory volume in 1 second. How much air can you breathe out in 1 second? Second. That's your FEV1, your forced vital capacity, and peak flow. So a lot of offices will have this thing down here where you can actually do an actual peak flow. These you may see, they're not actually as much part of the guidelines anymore. They're only for certain people. It's like tailored to the person. So if they're really reliable and this works really well for them, then great. It used to be where you blow into it. If you're in the red, you need to go to the emergency room. If you're in the yellow, it's a warning. Maybe you need to take your albuterol. And if it's in the green, you're doing well. So it's the same thing. And it depends on your age and your weight and your height, depending on where the red, yellow, and green will be. As far as management of asthma, it just depends. So if you have intermittent asthma, so that would be like a mild intermittent asthma, really all you need is your albuterol inhaler on you. If you have mild persistent, maybe you have to go on a steroid inhaler for a short amount of time when you're having an asthma flare-up. If it's moderate persistent, those people will have their albuterol on hand and be on a combination such as Symbicort or an Advair or the Dulera. And if you don't remember these drugs, kind of go back and look at the pictures of the slides. Severe persistent, you know, they're going to be an asthma. They're going to be on the albuterol to be used as needed. They'll be on a nebulizer at home as needed. And they will have a combination steroid with a long-acting beta agonist. Okay. All right, so this is just to give you an idea of how we prescribe stuff. So this is chronic asthma. Everything that we do as providers, we use guidelines for. Guidelines are there for a reason. Yes, they're written in pencil, not pen, but they're very highly recommended. It's based on research that's been done. So if someone has this intermittent asthma, as I mentioned, you put them on a short-acting beta agonist. Step 2, you can add this is a steroid ICS, intercorticosteroid. There's an alternative, which is that cromolyn, theophylline. These are just other names that I don't even know what LTRA is, but cromolyn, know your cromolyn. Know what your theophylline is, the methylxanthine. It's not used very often. So usually we're only going to this. Step 3, you either put them on a low-dose steroid, either a long-acting beta agonist, or long-term, I'm trying to figure out what the LRTA is. Now when I say low dose, that means, for example, Advair comes in 100, 250, and 500, low dose. I'm going to put them on 100. If I'm going to put them on a medium dose, I'm going to put them on 250. Now going up the step here, we're going to put them on more of a high dose. See this medium dose, high dose, high dose. So that would be like your 500, or like your Symbicort is 160 for high dose, and 80. I have the low dose on me now. And each step you need patient education, environmental control, management of comorbidities. You should go through that with every patient regardless, because if you could try to get this under control so you're not in here by just changing the environment, then that would be great. Also keep a short acting as needed for symptoms, up to 3 treatments at 20-minute intervals. That is for your nebulizers at home. Okay, so I hope that makes sense. If not, we can go over it in class. If you have an acute severe exacerbation, you need to be in the hospital, in the emergency room, and this is the initial therapy. They give you steroids through the IV. They give you nebulizer albuterol and ipratropium, which is your anticholinergics, and your oxygen. Drugs for exercise-induced asthma cause is bronchospasm secondary to loss of heat and or water from the lung. So we do have those out there. So with that, we talked about doing the albuterol inhaler 15 minutes prior, as well as doing cromolyn if needed, although it's usually just your albuterol that you're seeing. Remember about reducing allergens and triggers. Management of COPD. So it's going to be similar to the asthma, although we have anticholinergics that we add to it, which includes your Spiriva. That is your Incruse, which I talked about. And now there's actually a new one. It's called a Norolipta. It's an anticholinergic and a long-acting beta agonist. So it can be very confusing. There's a lot of inhalers out there. And you'll have to probably just look some of them up because there's so many new ones out there. Just remember, anticholinergics are only for COPD patients because we're relaxing that smooth muscle to prevent. So mild, moderate, severe, very severe. If somebody's very severe, they're on oxygen 24 hours a day. They're probably on oxygen at severe. Moderate, they're not on oxygen, but they're probably on a medium dose steroid with a long-acting beta agonist. If they're mild to moderate, also they're on an anticholinergic. What are the treatment goals? To reduce symptoms. So that seems like an obvious, right? Okay. Now one thing this is not for testing purposes, but just to let you know for future, if you see somebody on oxygen and they don't want to wear it, there is a really good study out there that shows that if you wear your oxygen 20 hours a day, you're actually improving your lung function. I know I said that there's really it's irreversible, which it really is, but there is a good study showing that oxygen can actually improve your lung function. It helps really halt that progression of the disease. So when people don't want to wear their oxygen, I tell them that. I said, you're reducing your lung function by not wearing that oxygen. There's different classifications we put people in. So depending on if they have a few symptoms, low risk, increased low risk, etc. And management is, which we talked about already. Some people are on the phosphodiesterase 4 inhibitors. That's like your Viagra because it's used for other things. I rarely see it used for that, but it can be. But they're on bronchodilators, glucocorticoids, as well as don't forget about anticholinergics. That should have been on this slide. And what are we going to do for management of that? We're going to do the short acting, which they're going to use their nebulizers. I'll use my dad as an example, who had severe COPD. He had a nebulizer at home, which he started feeling sick or more short of breath. He'd use his nebulizers at home. He always would have his albuterol, and he used it all day. He was on oxygen 24 hours a day at the end. So in the morning, he would get up and he would take his Spiriva. So he was on this anticholinergic medicine, and then he was also on Symbicort. So he was taking this medication, not this exact one. This is a sample. He was on the high dose of the Symbicort, so he was getting a steroid, a long-acting beta agonist to keep things open. He was getting the anticholinergic to reduce the muscle, like to cause muscle relaxation in the bronchial muscles. When he would get sick, he would have an antibiotic that he'd start taking that was on hand, that was prescribed from the doctor. He'd use his nebulizers about 4 or 5 times a day, and he'd have his rescue inhaler. But he really couldn't go out when he was sick. He couldn't really walk. But this is just giving you an idea what the severe thing is and what kind of regimen that these patients can be on. Oxygen, and what makes you determined to go on oxygen? Well, Medicare will pay for it if it's less than 88% on room air and walking around. So you have to make sure that's the only way Medicare is going to pay for it. So if these people are running at 92, we're usually pretty happy and don't need oxygen. But if they're in the hospital, I walk them around quite a bit, because when they're in bed, yeah, it could be 95 or 96, but get them up and walk them around and it can go down. And then you wonder what they're doing at home. You know, when they're sleeping, is it dropping down? And when they're going around, they're about their daily activity. Some feel like they don't need it because their body has some compensation, and so you feel like you don't need it, but you really do. When I say antibiotics on hand, the goal is to keep these people out of the hospital. You know, once you're in the hospital, can pick up other infections, and these people's immune systems are bad as it is. So these people will always have a cough. Again, these people were smokers for the most part, maybe secondhand smoke, but they have that smoker's cough, which I say there's no such thing as a smoker's cough. It's really COPD. You have to ask them if there's a change in their cough. They're always going to have a cough. It's probably never going to go away, which is why Mucinex a lot of times people will take too over the counter to help increase those secretions to get things out. So anyways, just some other things to keep on board for them. Yeah, but to keep them out of the hospital, which is why it's good to have antibiotics on board. All right, so what I would recommend is going back to the beginning slide, this one here, so you can kind of get it in your head, an idea of what these medications are and who they're for, etc. And we're going to go through these in class. If you watch this recording for class tomorrow, come in and say Big Bird, so that way I know you watched it. So that'll throw everybody off, right? Okay. And that is it.